Hi, everyone, and welcome to another episode of Dr. Gilbert Hosts. Now, today our broadcast is entitled Palliative Care and Parkinson's Disease, and we're going to be discussing lots of issues surrounding that topic. What is palliative care? Who does it help? Why is it important? How do you get access to it? Lots of questions everybody wants to know the answers to, and I'm very excited to introduce today's guest, who is Dr. Jori Fleisher, an expert in this topic. Now, Dr. Fleisher is the Leslie Nan Burridge Endowed Faculty Scholar in Parkinson's Disease Research and Associate Professor of Neurological Sciences at Rush University Medical Center in Chicago. She's a movement disorders neurologist and leads the Rush Advanced Interdisciplinary Movement Disorders Supportive Care Clinic, the Cure PSB Center of Care, and the Rush Lewy Body Dementia Association Research Center of Excellence. Dr. Fleisher completed neurology and global health equities residencies, a movement disorders fellowship, and a master's of science in clinical epidemiology, all at the University of Pennsylvania. She also has additional training in health services research, palliative care, and implementation science. Dr. Fleisher has several studies underway focusing on improving the lives of patients and families living with advanced movement disorders. Welcome, Dr. Fleisher. We are so honored to have you here with us today.
Thank you so much, Dr. Gilbert, for that warm welcome, and to everyone who is tuning in today, and to APDA for the really gracious invitation. It is such a pleasure to speak with you all today, and thanks for being here. So I'm really excited to start talking with you about this topic. I know lots of questions have come in. And before we dive into why palliative care, why are we even talking about this? I thought it would be helpful to kind of take a step back and think about, what do we know about Parkinson's disease over time? And I always want to put the warning out there of, just because we talk in general terms, every single person with Parkinson's is different. So you may get different results, right? So your course with PD is going to be different than anyone else that you meet. But broadly speaking, let's think about what we know about Parkinson's over time. So as Parkinson's progresses, we know that symptoms change, symptoms evolve, caregiver strain and burden rises, and it's actually already higher for family members and friends taking care of a loved one with Parkinson's than in conditions like Alzheimer's disease. We know that motor symptoms and severity increase over time, and we know that hallucinations and dementia become more frequent. Not everyone, but they become more frequent. We also know that people with Parkinson's disease over time wind up in the hospital for certain reasons. And those common reasons are infections, especially urinary tract infections, pneumonia, including aspiration pneumonia or coughing something down the wrong pipe. Falls are a very common cause of hospitalizations, dehydration, which can be really sneaky, and neuropsychiatric symptoms, which is the broad group to say agitation, hallucinations, delusions, depression. And so those are the things that wind people up in the hospital. And often when someone with Parkinson's goes into the hospital, we often think that you go in with one problem and you might leave with 5, because being in the hospital is a really dysregulating situation, and is a big risk factor for being placed in a nursing home or institutionalized. And over time, we know that people whose motor symptoms worsen and who have hallucinations, who have dementia, who have really increased caregiver strain, those are all risk factors for a person with Parkinson's being placed in a nursing home. What's the big deal? Right? For many people, that might be the right spot for them. And so there's no value judgment in people being in a nursing home. But what we do know, what's really concerning, is that people with Parkinson's, compared with folks with Alzheimer's disease or other conditions, people with Parkinson's disease do poorly in nursing homes. They have a higher mortality and morbidity rate. So they acquire more problems while they're in those nursing homes. Let's talk about what we don't know about Parkinson's over time, though, which is just as important, if not, I would argue, even more so. So we know a lot about early Parkinson's disease and even middle stage Parkinson's disease. People with early and middle stage diseases, and you might be thinking, how do I know what stage I'm in? And we can talk about that later. But let's put just roughly the first 5+ years, maybe even 10 years. Symptoms are well controlled. We can control them with medication, with exercise. That's when people are able to make it to clinic. That's when people are able to be recruited into research studies. So much of what we know about Parkinson's disease comes from you participating in research studies, but you have to be in clinic to be recruited to a research study most of the time. And as disease progresses, it becomes harder and harder for people to make it into clinic. And so if you're not showing up to us, I'm here in my clinic today, if you're not showing up to see me, then I can't ask you questions about it, what it's like to be at your stage of Parkinson's or what that experience is. And so people with more advanced Parkinson's are really missing from the research. They're often missing from clinical care. And so my particular interest has been this sort of in-between zone where people are becoming more advanced with Parkinson's, and there's a gap between where folks show up in the literature and research about medications that are being tried, and then we'll hear bad things that happen to people with really advanced Parkinson's in nursing homes or hospitals. People are in the middle, and we've got to be able to reach them and support them. And so what we don't know is how best to do that. Let's think about what we know about people with serious illness. So in general, what do people with serious illness want? And this could be folks with Parkinson's disease and other serious illnesses. So broadly speaking, people with serious illness want appropriate treatment of their symptoms. They want a sense of control. They want communication with their families, with their loved ones, with their healthcare team. They want care to be coordinated throughout their disease course, not to have to do a he says, she says between different providers. They want to avoid inappropriate prolongation of the dying process and inappropriate suffering. They want to relieve burdens on their family and loved ones and strengthen relationships with their loved ones. And what do care partners want? Well, it mirrors what their loved ones want. They want their loved ones' wishes to be honored. They want to be listened to and included in the decision-making process. They want honest communication and information, and they want it to be confidential and private. They also want 24/7 access. As things are changing, they want to know that they can pick up the phone and someone will answer if there's an emergency or there's a concern. They want and need support and assistance at home and practical help, like how do I lift my loved one out of bed when that's becoming challenging or they might not be able to help, and personal care needs as well. So what do we all want? Taking an even broader step back and getting to, wait a minute, isn't she talking about palliative care? So what we know from really large studies of adults in general is that the vast majority of people say that they want to die at home. And yet, the vast majority of people in the United States die in hospitals or nursing facilities. It's almost like we have this roadmap that here's our plan of what we want, and then this is sort of the road that we're taking, and they don't quite align most of the time. And I would like to suggest that we can build a ladder between that roadmap of what we want and what we get. And that ladder is palliative care. So what is palliative care? Let's talk about this. So palliative care is used, that term is used in a couple different ways. So palliative care is both a medical specialty, but it's also a broader approach to care. So oftentimes when people say palliative care, what they mean is specialized medical care for people with serious illness, focused on providing relief from symptoms and stress and suffering of a serious illness. What else? So the focus of palliative care is to improve quality of life and relieve suffering for both the patient, the person living with the disease, and their family, whatever that family looks like, right? And palliative care can be delivered usually by a team of specially trained physicians, nurses, other healthcare specialists who are working together with a patient's other healthcare providers to provide an extra layer of support. So for example, palliative care really came out of people being treated for cancer. And it used to be the sort of two separate poles as people were treated for cancer, chemo, radiation, all of these different things. And at some point, the oncologist might say, oh, there's not much more that we can offer. We're going to hand you off to our palliative care colleagues, right? And there was this idea that palliative care was separate. And that has really changed in the last several decades, even though that's still kind of the taboo that's out there. Palliative care and all of the other therapies really exist hand in hand when someone is dealing with a serious illness. So primary palliative care is this idea of palliative care, symptoms that are focused on quality of life, relieving suffering, and really seeing the person as a whole, delivered by a non-palliative fellowship specialty trained provider. So what does that mean? That means that your loved ones or your neurologist, your primary care physician, really is a primary palliative care specialist, even if they might not realize it. Right. So one sort of snarky comment that I sometimes say to my trainees is, unless someone is holding out on me, unless there's a cure for Parkinson's that we don't know about yet, everything that we do in treating someone with Parkinson's disease is to improve their quality of life and relieve their suffering. That should sound familiar. That's palliative care. So whether or not you want to call it palliative care, if you are treating someone with Parkinson's disease and you're trying to make their life better, you're doing palliative care, whether you want to call it that or not. And that's a little bit glib, but there's so much that we can do to improve symptoms, and that's really where palliative care starts. So let's move on to sort of where did this palliative care idea come from, and how do we take a more holistic approach to people? Palliative care principles address this idea of total pain of serious illness. And you might think, well, I have Parkinson's, but I don't really have pain. We don't just mean physical pain. So this idea of palliative care is to optimize communication throughout a serious illness, make sure everyone is on the same page, and as things are changing, we're talking about it. To manage intractable symptoms, that could be pain, that could be shortness of breath, that could be dyskinesias, that could be hallucinations. To alleviate suffering. And when we think about suffering and pain, this idea of total pain means not just the physical, not just, my feet are tingly or, my hand is cramping up, but psychological pain, spiritual pain, social pain, existential distress sometimes. A lot of times we talk in clinic with our families and we get the why me? I've done everything right. My faith tradition, makes me think that, why would God do this to me, right? I've done everything that I should do. That spiritual distress is part of this idea of total pain, and it's part of what palliative care seeks to address. And palliative care is there to address end-of-life care, but not just end-of-life care. So in Parkinson's specifically, we can do all of these things. We can manage symptoms. We can look at psychosocial support of the patient, the family, the care partners, spiritual well-being, plan and prepare for the future while also making sure that we are living in the moment and reducing caregiver stress. And I love this quote by Dr. Steve Pantelat, which is, palliative care is about living as well as you can for as long as you can. Rephrased in another way, we may not have control over the quantity of life, but we can really do something about quality in that quantity. So when is palliative care even appropriate for Parkinson's disease? I get this question all the time. And there's this myth, this misconception that palliative care is at the end. And we don't even necessarily have great tools to help us say when we're getting close to the end. But I love this figure by Dr. Benzie Kluger and colleagues who are really leaders in this field. This idea of the continuum of palliative care in Parkinson's is, so if we look on sort of the y-axis going up, those spikes and humps, every time those get higher, that says that a person or a family unit's palliative care needs or their total pain is higher. And this is different for everyone. But at the time of diagnosis of a serious illness, there's a spike in that palliative care need. There's a spike in the why me? Where am I supposed to find hope now? Why is this happening? Not just the physical symptoms that the person is presenting with, but how do I tell my family? How do I tell my job? All of these social concerns, that's also part of this total pain, and palliative care can be there to help then and at every one of these different time points along the way. That can occur for some people, but not necessarily all people. So does this actually work, right? You might be thinking, oh, this is very nice. This is a nice idea. Does it actually work? Well, In oncology, I mentioned that in the field of cancer and oncology, that's really where palliative care started. And there are many studies that have been done where patients have been randomized. They've consented and said, okay, I have stage 4 cancer. It's not treatable, it's not curable, lots of symptoms. And I sign up for a study where I will be randomly assigned to palliative care or usual care for my cancer that I would get otherwise. And interestingly, what they found in cancer was that the people who were randomized to palliative care not only had better quality of life, they lived longer. They lived longer because there's a focus on what matters and how can we make sure that we're focusing on that. And that's all well and good for people with cancer. What about Parkinson's disease? Well, more recently, thankfully, in the last couple of years, we've got great data coming out from many different prominent researchers. Dr. Benzie Kluger, Dr. Janice Miyazaki have published studies where they've randomized people with Parkinson's and related disorders to usual care or different palliative care models. And no matter how we slice it, no matter what that palliative care team looks like, it seems like the special sauce is a special team of interdisciplinary people coming at this from different angles: nurses, social workers, movement disorder specialists, chaplains, people focusing on the person, the family as a whole, and saying, what matters most? How can we help you achieve your goals? How are those goals changing? What else can we do? And it works. So my own team, we adapted this model, and we did a trial of home visits for people with more advanced Parkinson's disease, and that, using a palliative care approach, that also showed significant benefit compared with folks who received usual care. So something else that often comes up when we talk about palliative care is this idea of advanced directives. Don't you just want me to sign a DNR? Isn't that just what this palliative care thing is about? So let's talk a little bit about advanced directives and what that means. And I will caveat this with, it always feels like it's too early to talk about these things. This isn't a good time. Who wants to sit down at Thanksgiving dinner and talk about these forms? It's always too early to talk about these things until it's too late. So this is one of the best gifts as a person living with a chronic illness or as a care partner, to be able to have these conversations and know that your loved ones know what you want and what's important to you, and vice versa. So when we say advanced directives, what does that mean? Advanced directives are legal documents in which people express their wishes about the kind of healthcare that they want to receive, who will make the decisions about their care if they become unable to make those treatment decisions. So I mentioned earlier my analogy about the roadways, right? If palliative care is your ladder that bridges what you want with what you get to try to bring them closer together, advanced directives are the blueprints for building a ladder. So what kind of advanced directives out there? You can hear a lot of different terms thrown around. So a living will, this is different from a will in which you say, okay, I want my dear cousin Susie to get, the wardrobe. A living will is what I want in terms of the healthcare that I receive. A durable power of attorney for healthcare is who I want speaking for me in terms of healthcare decisions if I'm unable to speak for myself. You should always let that person know that they are your healthcare power of attorney. A MOLST or POLST form, or medical or practitioner order for life-sustaining treatment, is a shorthand document. Every state has a different one. They're usually one page, brightly colored, and it's a shorthand document that summarizes, here's who I am, here's who makes decisions for me, and in emergency situations, do this, not this, do this, not this, take me to the hospital, here are the things that I want. A do not resuscitate order, or what's more currently called a do not attempt resuscitation order, or DNAR, is one small piece of that. So speaking of one small piece of a bigger whole, I hope, and I'm sure questions will come in about this, but palliative care versus hospice, aren't they the same thing? They're not. So palliative care is a broad field. Palliative care is applicable from the day that someone says, I think you have Parkinson's. It's probably applicable before the diagnosis when you're having symptoms and wondering what's going on. Palliative care applies to anyone, any age, any stage of disease, with any serious illness, and can be provided at the same time that we're providing curative treatment. So people who are diagnosed with early treatable cancer are still eligible to get palliative care because it can help control the symptoms as they're getting their treatments. Hospice is a tiny fraction. So hospice is a small part of palliative care that applies to people of any age, but for whom a healthcare provider has in their best estimate, feels that the person's life expectancy is 6 months or less. So let's dig in a little bit more to that. So what is and when is hospice? Hospice is medical care and support for patients and caregivers when curative measures have been exhausted and life prognosis is less than 6 months. Now, you can look around my messy office. I have no crystal ball. I wish that we had really good prognostic measures that would help us say to the person in front of me in the clinic, I think you have this much time left. People are working on it. There's a lot of research going on, but we're still not great. We have some markers, but not a ton of them. And so we have some guidelines, but for many movement disorder neurologists or Parkinson's specialists, a lot of it is based on experience. And so if the provider is saying, I think that you or your loved one qualifies for hospice, what does that mean? What services are included in hospice? So I always tell people, hospice is an entitlement. Hospice is a Medicare benefit, just like prescription drug coverage or things like that. Hospice is part of Medicare. If you're receiving Medicare, it's part of what you got. So if it applies, you might as well use it or at least know about it in your toolkit, right? So Medicare mandates that a hospice agency, to be called that, has to contain an interdisciplinary team of hospice professionals. They have to be able to support you with home medical equipment, like a hospital bed or wheelchair if needed. They provide medications. They offer short-term respite care, where the person with the disease might be able to go to a skilled nursing facility for a short number of days so the caregiver can get a break. They have to be able to provide continuous care. What does that mean? This gets tricky. So they're not providing continuous care in the home, but it means that there's a 24/7 phone number that you can call and someone will always answer. They have to be affiliated with an inpatient unit, someplace where if the needs of the person receiving care are too great to be delivered in that person's home, the hospice team can say, you know what? I think we need to call in some backup. Let's move the person from their home to more of a hospital setting where we can provide more pain control or symptom control. They have to be able to send a nurse, typically a social worker, to provide some routine home care. Usually that's a nurse about every week. As symptoms are progressing, it might be more common. And I think this is an unsung part of hospice. When the person with the serious illness passes, when they die, hospice means that the care partners, the family, is entitled to bereavement support for up to 13 months after the patient's death. Why 13 months? Because the anniversary of a death is really, really difficult, and hospice recognizes that. So what kind of supplies does hospice provide? What exactly do they give you? So hospice can provide incontinence supplies, wound care, oxygen if a person needs it, although that's less common in Parkinson's disease. They can provide a hospital bed. The team varies depending on the agency, but typically as a nurse, a social worker at least, they may have a chaplain as part of their team. They may have friendly visitors. They may have music or art therapists as part of their team. They will provide medications, but the medications are not just a continuation of the prior regimen. So if a healthcare provider is saying, I think that you or I think that your loved one qualifies for hospice, then what? Do we sign a form or someone shows up or what happens exactly? So we tap the brakes in Parkinson's because there are a few things that we always want to make sure we've got in place. We want to set ourselves up for success before hospice referral. So one really important thing to know is that for Medicare rules, scientifically, this doesn't make any sense, but physical therapy, occupational therapy, and speech therapies for most hospices are not covered. So before a person enrolls in hospice, they have to finish or wrap up or withdraw from any of those kind of therapies that they're receiving. And that can be a really emotional sticking point for a lot of people. Another point is that, as I mentioned, hospice will provide a nurse to come and check on the patient, and maybe weekly. Sometimes it's more frequent than that. A social worker, supplies, all of these different things. But I often have people say, Jori, I can't do this anymore. I need more help. I guess we're ready for hospice. When can they come and how many hours are they going to be there? And hospice does not provide paid caregiving. So hospice is not a replacement for any paid caregivers that you might have in the home. It's not, it's not a time where the loved one, the primary caregiver can, go out for a couple of hours to get much needed time away. It's really visits. And so if you have a paid caregiver helping to take care of your loved one, they typically stay on board. What else? So is there one hospice agency? How do I even find a hospice agency, right? You can interview different hospice agencies, and you don't have to wait until the healthcare provider says, I think that your loved one needs hospice now. If this is something that is concerning to you, if this is something that makes you anxious, or that you're just curious about what are the options in my area, you have every right to do an informational interview. There are lots of different hospice agencies, and you can ask them what their services look like. How familiar are they with Parkinson's disease? Will they communicate with your referring physician? So some neurologists want to stay engaged and want to stay on board as a consulting physician when a person transitions into hospice. Other neurologists or primary care physicians or other folks may say, you know what, I don't know that I have as much to offer now. I don't have a lot of experience or expertise with end of life, but hospice does. Let's let them take over, but you can always call me with any questions. So there's a balance there, and it's helpful to ask the referring team and the hospice team what to expect. And you also want to ask whether they have an inpatient unit and where that is. So they might have a beautiful unit that hopefully you never need to use, but if it's 50 miles away from you, that might be a consideration. Before signing on the dotted line and saying, okay, we're enrolling in hospice, you want to go through the person's medications and prepare to minimize them. What does that mean? I told you that palliative care, and particularly hospice, is focused on symptoms and comfort and quality of life. So hospice, because it's a Medicare benefit, also has kind of strict they only receive a certain amount of money from Medicare to provide care for people. And so they have to make some tough choices sometimes. And often the place where we see that is in medications. So sometimes patients have been on medications for decades, right? Maybe you've been on a cholesterol medication for years and years and years, and you understand and you've listened to why taking care of cholesterol is really important. But if life expectancy is much shorter than we'd hope, and that cholesterol medication is really just there to prevent a heart attack or stroke 10 or 20 years down the line, the benefit of that medicine now really no longer justifies having it on board. So can we get rid of that pill? Absolutely. Can we get rid of that baby aspirin? Can we get rid of some of the vitamins? Absolutely. And so talking through those medications can be really helpful before going into hospice, so that it's not a shock to the system if the hospice doc says, I don't think you need this, 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 and this. And it can be very helpful to talk with your Parkinson's specialist to say, okay, what has to stay? Or if my loved one is having trouble with swallowing, how do we adjust that? Will the hospice team know about that? Can they call you if they don't know about that? So those are all important things. If there are medications that you need, that your movement disorders neurologist might say, absolutely you need this, but it's really expensive, hospice may not cover it. It's a good idea to get a 90-day supply, if you can, before enrolling in hospice. And if that's not possible, thinking about switching to lower cost options. And in particular, in people who receive botulinum toxin injections, either for drooling or for contractures, most of the time, Medicare does not cover botulinum toxin or Botox injections when someone's in hospice. So get those injections right before you enroll in hospice. And it's usually they're effective for about 3 months. So it's at least covering you for some of that time. And hopefully you reach the 3-month mark and you can think about, do we want to pay for that out of pocket or not? Is it still beneficial? The other thing is hospice teams will usually bring you a comfort kit or a medication kit to keep in the home that's there as sort of an as-needed basis, so that if something is changing, if you call at 3 a.m. and say, my loved one seems kind of agitated, I'm not sure what to do, the nurse or the physician who answers the phone will guide you through, okay, I want you to go over to the box, open up the box, take out the medication labeled XYZ. Here's what we're going to do. So for many other conditions, there's a medication called Haldol, which can be actually a good treatment for agitation and confusion. But it is not okay in people with Parkinson's disease and related disorders. It can make them worse. So anytime I am enrolling anyone in hospice, I always make sure I communicate with the hospice team, no Haldol in the kit. And if they bring it to you, that's fine, but you can just hand it back to them and say, thank you so much. We will not be using this. No, thank you. And ask them to take it back. We will never use that in someone with Parkinson's disease. All right, so coming to the end, there's so much more we can talk about. I want to take all of your questions. I did want to leave you with a couple of great resources if you want to learn more about this. So here I've put on some websites that are fantastic for thinking through these conversations. Sometimes it's really hard to start thinking about what matters most to me, and do I even want to how do I bring up palliative care? How do I ask my loved one, or how do I tell my care partners that I want to have these difficult discussions? You are not alone. So the Conversation Project, 5wishes.org, and Prepare for Your Care are fantastic resources that you can look at before or after your doctor's appointments to think through some of these issues and more, and start to have those conversations. And if you're interested in learning more about palliative or neuropalliative care, I want to highlight that inpcs.org. It's the International Neuropalliative Care Society. And that's open to healthcare professionals, but also people living with serious illness, their care partners, their families. There's lots of information on there. And hospicefoundation.org can help you find places in your area, has great questions if you're interviewing. So with that, I want to thank you so much for your attention today with this often fraught topic, but it's so important. And I want to welcome back Dr. Gilbert to help take your questions.
Fantastic. So thank you so much, Dr. Fleisher, for that important information, very clearly presented. So thank you so much. And now we already have many questions that have come in through the live chat. So please submit them now. And we encourage you to ask whatever is on your mind. Now, in order to participate in the live chat, you'll have to log into YouTube or Facebook. And I want to make it clear that we may display your question and we may display your name and photo that you're logged in with. So please be aware of that. So let's start it right off. We have a great question from Christine. Now, I know many people who are watching now are not at late stages of Parkinson's. They're early on. And many have been asking, what are some of the best types of palliative care that might be a worthwhile endeavor to look into for someone who's been newly diagnosed or diagnosed within the last 5 years? This question from Christine.
It's a great question, Christine. So I think, thinking about this holistic idea of palliative care is thinking about what is it that you feel like you're not getting? What is it that you feel like could be better? Is that a symptom? And if it's tremor, if it's dyskinesias, if it's depression, anxiety, fatigue, these are things to say, here's what matters most to me. I always encourage people, when you're going in to meet with your healthcare professional, make that list ahead of time, right? Because when I'm thinking about, the patients I'm going to see that day or the next day, I have in my mind, here are the things that I'm concerned about, and I want to make sure I bring up, but I want to know what's at the top of your list, right? So put items at the top of your list that are important to you and say, look, doc, my sleep is really messed up and I feel like I'm not sleeping well. Can you help me with that? And if that doc or that healthcare provider says, that's really outside of my scope of expertise, okay, totally hear that. Who would you recommend? And it might be a palliative care doc, but it might be a sleep specialist, right? If you're having pain, someone might refer you to a pain management specialist or a palliative care doc, right? It could be mood symptoms. It could be the stigma of coping with a new diagnosis. I don't know how to carry on with my life the way that it was before. For some people, there's a before and there's an after. Before I was, before I was, I didn't have this diagnosis. Now I have this diagnosis, and this living in the after is really different. And I don't know how to cope with this. I don't know how to talk with people about this. And bringing that up, they might say, I don't know if I have the skills, but maybe a therapist. Let me refer you to my colleagues. I think these are all different ways in which palliative care can be helpful, the approach, if that makes sense.
Fantastic. Thank you so much for that. Many people, both before this broadcast and now, are asking the same question. So it's clear that insurance covers hospice. How do you get insurance to pay for palliative care?
So palliative care, if you're seeing a palliative care specialist, so let's take the step back so I put on my neurologist hat, and I see patients in my clinic as a neurologist. who is coming from a palliative care perspective. I'm sort of thinking about these broad topics. But when I have challenges with folks where I go, I don't know how to manage this complex pain, or I've tried having conversations about what matters most to this patient and I don't feel like I'm getting anywhere, I will refer them to my palliative care specialty colleagues. And you may need a referral, just like if you would need a referral to see the neurologist, depending on your insurance. You might need a referral from your primary care doc or from another physician, but it should be covered. You want to make sure that they're in network. And ideally, if they're in the same system as whoever else you're seeing for your Parkinson's care, that will help with that continuity of care so that they can see each other's notes. And if they have questions or someone goes, wait a minute, I'm not quite sure, are you sure that's the right medicine for them? Maybe we might want to change this. It makes it easier for people to reach out and connect.
Very good. Excellent. So we have a couple of questions along these lines, which is, this is a question from Karen. So my movement disorder specialist is hostile to the concept of palliative care before a late stage of Parkinson's. How can I help him or her get the education that you are now providing?
Karen, that is such a great question. I think maybe some background is helpful, which is that we know that there's so much taboo and stigma about this idea of palliative care, right? People hear palliative care and they think hospice, and they hear hospice and they think that means the end, we're giving up, there's nothing else that we can do. That's often the public perception, and I will tell you, that's often the perception within healthcare too. And it's wrong, but that doesn't mean that that idea doesn't need time to still evolve. A lot of times there's sort of this idea that, it takes 20 years for a new finding in medicine to really percolate its way through until that's the standard of care. And there's been so much more acceptance of palliative care as something that goes with traditional care and not something apart from it. But that's still percolating along. So for some healthcare professionals, they may hear palliative care and they may think that that means a failure on their part. They may think that palliative care is something different. And if you're asking for palliative care, it's because they are not able to meet all of your needs, and that's a failure for them, right? And that's really challenging. So there are a lot of efforts right now to specifically educate healthcare professionals about Parkinson's disease and palliative care, and demystify this and tell them nope, you can do this. You can do this, right? You can serve your patients in this way. You actually already are. We might just need to kind of reframe the semantics. So sometimes we frame it as supportive care. People have actually looked at this and said, well, supportive care sounds palatable. Palliative care sounds terrible, right? And if so, my clinic is called our supportive care clinic. It's palliative care, but we don't want people to run screaming. And the same thing applies to healthcare professionals too. So if they're hostile, instead of framing it as palliative care, you could take the approach of saying, Doc, here's where I feel like I'm really suffering. Here's what's most important to me right now. Are you the right person to help me with this? Or who would be the right person to help me? Right? And give them that opportunity to say, oh, well, I can get this. They might not see that as palliative care. They might just see that as part of their practice. And I think it really varies from person to person. But I think in the next 10, 15 years, there is this tidal change where we're going to see the wave of change, and this will become much more mainstream.
That's very, very helpful. Thank you very much. We have a question that's, again, been coming in from many different angles, which is coordination of care. So it's clear that you're continuing to go to your neurologist, but there's lots of other specialists that you've been talking about. How do you make sure that this palliative care entity is coordinated among the different physicians?
It's a really good question. And I think this is something that we all struggle with, all the different models of care, trying to, facilitate that continuity, but also not have everyone step on each other's toes. So something that I think is really helpful and that I try to do in my own clinic is, instead of saying, okay, I just want to see you back every 3 months, just to come back every 3 months, right? I ask my folks, when do you feel like it's right to come back? And some people will say, I don't know, Doc, what do you think? Right? But for some people, they'll say, I have too many appointments. I don't want my life to be focused on going from doctor to doctor to doctor, right? They know where I am. They certainly know how to reach me. So if we want to say, let's space it out on your time frame, right? And I think that can apply to other physicians too. Are you going in, to see other healthcare professionals and other disciplines just because that's kind of the set schedule and that's kind of how we've been doing? And is that appropriate anymore, right? So I think it kind of depends on every person and every situation and the symptoms that are bothering people and the things that matter most to people. But, do you need to have, an every 6-month dermatology skin visit necessarily? If, things have been okay and you're doing pretty well? Probably not, right? But I think that depends on everyone's individual situation.
Yeah, that makes a lot of sense. Trying to simplify things and yet get the important people to communicate with each other. That's the goal, and it's hard, but it can happen. We have another great question, which is, you mentioned hospice is a part of palliative care that kicks in towards the end of life when life expectancy is approximately 6 months. How is that determination made for someone with advanced Parkinson's? It's a tough question.
It's such a tough question. It's such an important question. So there are no good guidelines right now. There's, nothing that Medicare uses. So there's no checklist where if I say, I think, my patient with Parkinson's qualifies for hospice, there's no one at Medicare who goes, okay, do they meet this? Do they meet this? Okay. Yes, they do. Oh, no, they don't. It really is primarily provider experience and expertise. But what do we use? What do the providers use to actually guide that? So there's research that shows that when people are having unintentional weight loss, particularly if their body mass index, which is a ratio of weight versus height, and really looking at the change in that over time. So when people are having a lot of unintentional weight loss, that to me is a signal, and that's borne out in the research, that a low body mass index is a good predictor of survival less than 6 months. Frequent hospitalizations, so recurrent hospitalizations for sort of these Parkinson's related issues that I mentioned on the very first slide. So aspiration pneumonia frequently, or having pressure wounds, or having really, really frequent urinary tract infections. If those are happening frequently over the course of a year, those may be a sign that the person is reaching the end of life. When a person is spending the majority of their day in bed, or the majority of their day, or more and more of their day, is spent asleep rather than awake. When we see that sort of transition of, my loved one could sleep for 20 hours straight, or I wake them up, I feed them, they're awake for a few minutes, and then they kind of drift back off, and they're sort of in that hazy daisy place for a lot of the day. That can be a sign for many people, especially in combination with those recurrent infections, with less mobility, that we're reaching the end of life. And so those are all sort of triggers for at least considering a hospice referral.
Okay, thank you. Very helpful. We have a great question from Jori. Are there different palliative care specializations? Are you looking for a team that specializes in Parkinson's disease?
That's a great question. So I would love to tell you, yes, you should absolutely find a team that specializes in Parkinson's disease. They are few and far between, but they're increasing. So I think, if you are in a place, if you're, at various centers of excellence, if you're seeing a movement disorders neurologist, it's worth asking them, do you work with a palliative care team? Can you refer me to a palliative care team? What's your collaboration like? Do we just, all right, I'm not sure, I don't really do palliative care, but I send people to palliative care and I work together with them. That's great, right? That may be exactly what a person needs. That might be the bandwidth that healthcare professional has. And that's fine. And so, asking, who do you refer to? How do you work together? And then asking that palliative care professional, what's your experience with Parkinson's disease? Because for many folks to become specialized as a board certified palliative care and hospice physician, people are often coming from internal medicine and then doing a fellowship in that, doing additional specialized training in that. But there are some neurologists who will do their neurology training and then go do a fellowship in palliative medicine. So you may be lucky enough to see one of these unicorn neuropalliative care specialists who really have training in things like Parkinson's, in ALS, in neurologic conditions, and palliative care expertise all together. Or you may be seeing a palliative care physician who spends the majority of their time taking care of people with cancer, heart failure, end-stage kidney disease, but also certainly sees different neurologic conditions.
Got it. Okay, that makes a lot of sense. And obviously there's a lot of variability around the country. As you said, there's some places that are great at this and probably getting more and more common as the understanding of palliative care evolves. So that's important. And here's a question that sort of touches on that from Deborah Kay, which is, if I ask for palliative care, so I reach out to my movement disorder physician and say, I'd like to have access to palliative care, will I be steered toward hospice given the poor education and communication that we've talked about?
I think it's a great question, Deborah Kay. It really depends. I wish I could tell you, no, absolutely not, that won't happen. I think it really depends on your entry point, who you're asking, and the perspective from which, and the education that they have about all of these issues, right? So there may be someone who just thinks, they still think that the Venn diagram of palliative care and hospice is just an overlapping circle. If they think that's the same thing, they're going to go, well, I don't know, I don't think they qualify for hospice, but I guess here's an order, right? Hopefully, even if that's the case, usually a palliative care and hospice, most hospice agencies offer both palliative care and hospice. And I want to clarify that a little bit. So when we think about a hospice agency, usually this is an agency that is providing care to someone in the home. And there is this spectrum of home palliative care and home hospice. So home palliative could be essentially for anyone, but home palliative is often most useful for folks with like COPD, with chronic lung disease, with heart failure, with things where they might need, oxygen, they might need some pain control, they might need other things, but they don't qualify for hospice yet. And there are things that could be provided in the home. Often, what we found to be the case is that palliative care delivered by outpatient folks like myself, like my palliative care colleagues, neuropalliative care colleagues, you're coming in to see us, you're saying, here are the issues right now in my Parkinson's, in my life. What can you help me with? What's Parkinson's? What's not? Take the whole picture. What can you do here? That's sort of outpatient in the clinic palliative care. Home palliative, where an agency is coming to you, a nurse is maybe coming to visit maybe once a month for sort of home palliative before hospice. Oftentimes, those home palliative healthcare professionals don't have a ton of training in Parkinson's. So they might come out, see the person once or twice and go, they don't have pain, their oxygen looks okay, their vital signs look okay. All right, call us if you need us. They may not have a lot of training in Parkinson's disease. So there's kind of this gap. And so often we'll have people, really receive the majority of their care from their neurologist, their movement specialist, the team as an outpatient. And if, only when they're sort of transitioning into hospice, that's when we refer to a hospice agency. But if your healthcare professional is referring you to a hospice agency and it's not appropriate, typically the hospice agency will send out a nurse, they'll come evaluate the person, and they may go, I don't know how to tell you this, but you look too good for hospice, right? And that's, that can be a wonderful thing to be told for some people. And then you kind of go back to your healthcare provider and say, saw hospice and they think I look good. So what now? And hopefully the hospice agency can also offer some recommendations too.
Great. So a conversation to be had, which is great. We had a few questions come in, which is along the same lines, a little bit of a different topic, but very related, which is the conversation about living at home versus living in a facility. We had one question come in specifically, what factors should you consider moving a person to a nursing or memory care home? Because my 80-year-old father is the caregiver, my mother depends on him, but it's affecting my father's health. How do you balance those things for quality of life on both ends?
This is the question, right? This is such a hard question. And it's so dependent on every individual family and situation to some extent, because for so many people, the financial considerations here are huge. And unfortunately, in our country, we don't have a great network of support for older adults in general, for people who need additional care in general. We certainly don't have enough support for caregivers. So I think it's really, factoring in a lot of different things. We know from our own research, my team's own research, that family caregivers of people with advanced Parkinson's disease, Parkinson's dementia, Lewy body dementia, they have an incredibly high risk of high blood pressure, diabetes, depression, back pain, which should not be surprising. A lot of times, you're the ones doing the lifting and the transferring. And so the care partners are often getting hurt and getting strained. And so if the care partner is really feeling like, I can't do this anymore, right? But is trying to tough it out and struggle and suffer, don't let it get to that point. And, for some people, one option is to bring in extra care into the home. So financially, if that's possible, and supply and demand wise, if that's possible, and those are two different but both very important issues. There are not a lot of paid caregivers out there. It can be very hard to find someone that you trust that works well with your loved one. It can be very hard to afford. And it can be very hard to break that privacy barrier and let someone into the house and know, what are they supposed to do? Are they just sitting here and watching me till I fall? There are all kinds of great resources out there to help. What do I do with a paid caregiver? How do I find one? But having someone in the home with additional paid caregiving support, or reaching out to family, often we'll say, how can I help, to the primary caregiver? And sometimes it's so overwhelming for that primary caregiver because there's so much noise of all the things that need to happen and all the moment by moment change. They can't even take the time. They can't find the space to say, here's the thing that would be helpful, right? So if you're not that primary caregiver, offering and saying, Dad, can I set up recurring grocery delivery every week? Would that be helpful? Can I just take that off your plate so it's one less thing to worry about, right? Thinking about ways that other people can bring things into the home, whether it's direct caregiving or support, can be very helpful. But on the flip side, if financially that is just not possible, which is the case for many, many, many people, right? Then, or if safety is an issue, if the person with Parkinson's disease is not safe in the home, if they're falling frequently, if they're trying to wander out of the house, if they're being aggressive or agitated towards their care partner and they're harming their care partner physically, which is a big risk, right? Then it's no longer safe for anyone. And so that's when looking into a facility, asking, similar to hospice, asking, what does this look like? Who's the staff? Who's going to be interacting with my loved one on a daily basis? What's your visiting policy? Are you going to roll your eyes when I come and see my loved one every single day if that's what I want? How are you with Parkinson's? What's your experience been? Tell me what that looks like. If my loved one needs extra support in the facility, are you open to them having a paid care partner who might come and sit with them for an hour or two a day just to give them a little extra enrichment, right? All of these things, it's such an individual choice, but those choices are out there. And, it's trite, but for those of you who've gotten back on an airplane recently, the flight attendants still say, put your oxygen mask on yourself first before you put on the person next to you. If we are not supporting our care partners, they cannot partner in care. They cannot give care if they themselves are too sick and too burnt out to be able to provide it. So many of my care partners and spouses and adult children and friends and neighbors are like, no, I can handle this for a little bit longer. And they're sitting there and the bags under their eyes and the exhaustion and the pill alarms are going off, left and right. This is hard. Acknowledging that this journey can be difficult and challenging and wonderful at other moments, but that the caregiving can be hard. Acknowledge that and validate that and give yourself that break. And if it's just an untenable situation, it's okay to say that and to try to change that situation. It may not be perfect, but we don't want everyone getting hurt in the process.
Thanks so much. I think that it's very helpful words to hear from many people who are listening. So thank you so much. Amazingly, we have really reached the end of our time with Dr. Fleisher. We're just going to squeeze in one last question, which I think is maybe just a summary question to help people really formulate what this palliative care thing is all about, so that we wrap up on a more upbeat note, which is, somebody asked, now DBS and Parkinson medications, they're not curative, as you mentioned. So would these be considered palliative treatments?
Yes, they would be, at least to this Parkinson's neurologist. Everything that we do is palliative. Exercise. I know there were all the questions that came in before today. What's the best kind of exercise? The best kind of exercise is the one that you'll do. And exercise is palliative. Exercise is helping with symptoms, right? Anything that brings you joy and meaning and hope is palliative. And that's not a dirty word. That's a great word. So I know Dr. Janice Miyazaki once said she tries to help people cultivate a portfolio of hope. I love that. That's what this is about. Is I wish that the Parkinson's wasn't there. I wish that things were different. But that aside, what can I cultivate? What can I focus on that brings me meaning and joy and lets me not focus on the disease, right? That's what this is all about. Get those directives done, get those documents done, and then out of the way so you can focus on living in the moment and being present for all of those things that bring you joy.
Fantastic. Thank you so much for all that wonderful information, for that upbeat ending, for that inspiration. We really appreciate you being with us today. And we also want to thank everyone for participating in today's discussion. It was very informative to hear everyone's thoughts and questions. Now, if you know someone who missed today's program, if you joined late, if you'd like to watch again, this recording will be available later today on our YouTube channel. So please access it there. And don't forget to subscribe to APDA's YouTube channel, and you can watch new videos, repeat videos, and also the live broadcasts. Now, remember, APDA can help you connect to resources that you may need. You can call us at 1-800-223-2732. Visit us on our website, apdaparkinson.org, and you can explore all that we have to offer for you. I want to mention before we leave today that our next episode of Dr. Gilbert Host will be Wednesday, October 26th at 3 p.m. At that time, we'll be discussing another extremely important topic, mild cognitive impairment and Parkinson's. Now, mild cognitive impairment is a state in which a person's independence and functioning are not impaired by changes in their cognition, yet their cognition is not what it used to be. And this is a situation that many find themselves in, and we're going to delve into that condition in our next broadcast. So be sure to stick around for a few final messages. Before we go, I want to thank you once again for joining us today, and we hope to see you soon on another APDA program. Have a great day.
Hi, I'm Leslie Chambers, the President and CEO of the American Parkinson Disease Association. Each month across the country, APDA is providing support groups, exercise classes, and educational programs like this one to support the Parkinson's disease community. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. If you enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Your gift can help APDA support people living with PD through local programs, reliable resources, and groundbreaking research designed to find treatments and ultimately the cure for Parkinson's disease. Please donate today at apdaparkinson.org/donate. And thank you so much for your support.